Psychiatry, and I had joined in December 2025. I'd like to take this opportunity to talk about an interesting but nevertheless a less discussed topic in scientific forums, that is transplant psychiatry. And this is the domain which we are also trying to expand in our department as well. So the outline for the seminar will be as follows. First, we'll discuss about what the history was like, landscape, and why does transplant psychiatry even matter. Then we will go through the continuum, what happens pre-transplant, peri-transplant psychiatric care, what happens after the transplant, and what has been our experience so far, and what are the points to be learned and scope for improvement. So coming on to the history and landscape, this is a relatively new branch. It's around 1980s when transplants were increasing. The consultation liaison psychiatry started to become part of transplant clearances. Gradually, from 1989 to 2012, the opinions shifted from unstructured opinion to proper structured ones, utilizing certain psychometric tools, which we'll be discussing later. In 2018, the Transplant Psychiatry Special Interest Group was then introduced under the Academy of Consultation Liaison Psychiatry as a distinct subspecialty. They started making joint recommendations for psychosocial evaluation for transplant candidates. Globally, today, transplant psychiatry services are present mainly in academic transplant centers like Mayo or Stanford, which was the birthplace of the CyPATS tool, which we are also using. Yet still today, in most centers, transplant psychiatry is still embedded within the consultation liaison psychiatry. In India, AIMS and PGI had co-authored the first Indian Psychiatric Society clinical practice guidelines for the psychosocial evaluation of transplant psychiatry patients. However, in most centers here as well, the structured transplant psychiatry services are still uncommon. This positions our institute to become one of the few Indian centers where we can have structured, protocol delivered psychiatric assessment across the continuum. Now, why does this branch even matter? Kimura et al. In 2023, by assessing 1,000 recipients between September 97 to July 2017, had identified almost 1 in every 3 transplant candidates have comorbid psychiatric disorders. And they found out that comorbid psychiatric disorders significantly were associated with shorter survival time. In another systematic review and meta-analysis done by Dew et al. In 2025, they pooled 27 studies and they found out that there was 65% higher mortality risk with pre and post-transplant in candidates with pre or post-transplant depression. Now let's start with the continuum, that is the early pre-transplant psychiatry. We'll start with a few case anecdotes that we have seen in our experience and then followed by some evidence. So the most common patients that we see here are often at the early pre-transplant at the state of CLD. One such anecdote is 55-year-old man who had alcohol-related cirrhosis was referred for alcohol dependence management. Mostly these patients have multiple relapses and last intake is just a couple of days prior to presentation. The intervention which we do in such patients is for a structured interview to identify the severity of substance use disorder, to see what are the associated biopsychosocial risk factors, and to assess for any comorbids, personality or psychiatric factors. The management is then divided into short and long-term management, when in the short term we try to detoxify and manage acute symptoms, engage them in motivational enhancement therapy, and try to identify relapse prevention triggers. In long term, it's not just about giving them anti-craving, but also to keep them adherent to regular treatment and follow-ups and to address any comorbid biopsychosocial issues or mood symptoms. So the aim at this stage is to initiate management as early as possible so that they might not have to undergo even transplantation or the illness might not get severe. The second point of contact with patients during the continuum is during the pre-transplant clearance state. So recipients who are being planned for transplant, one such case was 29-year-old female who was having chronic kidney disease, was being planned for kidney transplant. Unfortunately, she was diagnosed with depressive disorder and on assessment with Hamilton Depression Scale, she was having moderate depression. After detailed history and mental state examination, we found that she was in need of pharmacotherapy as well. We started low when engaged her in supportive psychotherapy. So here the aim is for management of any comorbid psychiatric condition to avoid worsening and ensure better prognosis, henceforth quality of life. Now, it's not just the recipients who come to us during this point, but also donors, and their mental health is equally important. One such case was a 33-year-old female who had been referred to us for donor evaluation. She herself was undergoing panic disorder with generalized anxiety disorder, and that too up to moderate anxiety. Again, we explained to her about her condition, why her mental health is important. She was also having caregiver burden. So all of those things were addressed separately. There was a lot of strained relationship between her husband. So supportive sessions were conducted. Medication at low dose was started, and they were advised for regular follow-ups. So management of comorbid psychiatric condition along with supportive sessions for the couple counseling was initiated. Another interesting case was regarding a prospective donor for her brother, but she had come for clearance, but she herself had had an experience of acute psychosis 3 months back. It was so severe that she had to be admitted. She was started on multiple antipsychotics, none of them rationalized in the proper way, and today she was not taking any of those medications. During the transplant clearance and capacity assessment, she had persistent suspiciousness against her in-laws. Because of this, we had also doubts of covert coercion as well. So we psychoeducated the family members, although they were very eager for the clearance. We educated them about her mental health, how that can be impacted during a process of transplantation. But luckily, acute psychosis is something which can achieve remission. So we initiated her on a proper treatment, and for now, the procedure has been deferred until she achieves adequate psychiatric stabilization. Yes, sir. She gives her consent and she cannot in the state. So, ma'am, her insight was partial. While she was having capacity to consent for this, but it seemed it was more of coercive. She was able to communicate, but she was not completely psychotic. Because of the certain medication, the effects had not worn out completely. So she was able to hold conversation. She was able to show that she wants to get the transplantation done, but her understanding about the procedure was not as in depth as it should be for a donor. So we'll also come to that. So it's not just what we do to detect psychiatric comorbidity and assess comorbid substance use, but we also try to have capacity assessment in detail along with psychosocial assessment. What do studies tell us? Now, alcohol-related liver disease are one of the most common indication for liver transplant worldwide, including our country. Neurotic disorders such as anxiety and depression are found up to 49% and 34% respectively for candidates on waiting list. So in such cases, psychiatric screening can help to identify and treat early in the continuum. When it comes to capacity assessment, we need to satisfy 4 components. Whether does the candidate understand the nature of the illness as well as the nature of treatment? Can they appreciate the foreseeable consequences of making the decision or of not making the decision? Are they able to weigh the pros and cons of making the decision or not making the decision? And can they communicate the decision clearly? Even if one of these are absent, then there is a doubt to capacity. This concept is very dynamic. Like that example, a person having capacity for one decision might not be having capacity for another decision. And this holds special relevance in case of living donor evaluation, those with active psychotics or neurotic conditions, which may or may not impair capacity to make informed decision, along with neurocognitive impairment. So while at that point the patient appeared to be slightly ambivalent, but we felt with treatment she will be able to come into remission from the acute psychosis. In case of minor recipients or medically unstable patients who are lacking capacity, in such cases, emergency clearances are done through nominated representatives elected for surrogate consent. Now, third is regarding the addiction psychiatry. When patients who had had history of alcohol use or any other substance, it's not just important to understand the severity of use, but to understand past abstinences. Why did the patient stop? What maintains that abstinence? And why did he relapse again? What were the triggers? Is the stage of motivation strong at the current state? And what will happen after transplant? Who will be monitoring the candidate's recovery? All of these are the recovery capitals of the patient, where we try to understand the family support, occupation, and insight. Now, these are variables that can predict long-term outcome. Another topic of discussion was how long exactly should a candidate be abstinent before being taken up for transplant. Previously, there was a 6-month rule which was widely adopted, but latest studies have shown that this 6-month rule has poor correlation with post transplant abstinence. So, even carefully selected patients with alcohol associated hepatitis can undergo successful transplantation without meeting this period duration, provided that other psychosocial factors are taken into account. So currently, our preferred assessment approach is that we need to have validated psychometric tool, comprehensive evaluation, and consider all psychosocial factors and not just the duration. Finally, coming on to psychosocial assessment. Now, multi-informant assessment is always recommended for transplant psychiatry evaluation. Reason, family members help us identify higher risk candidates who need close monitoring. They also provide information on gaps on treatment adherence, personality traits, coping skills, and social support. So when do we take a pause? Either if there is active psychosis, severe depression, impaired capacity, active substance use, repeated treatment non-adherence, weak caregiver support, or coercion. They are not just red flags or disqualifiers, but these are just flags which help us to get deeper evaluation and optimization before giving clearance. Now, our tool SciPad operationalizes this clearly by categorizing such patients into high-risk patients who can have regular follow-up. Now, this is the SciPAT scale, that is Stanford Integrated Psychosocial Assessment for Transplantation. It is the most comprehensive one till now, given by McDonald in 2012. It has 4 domains, which encompasses patient readiness level, what is the social support system, what is the psychological stability and psychopathology of the patient at present. So at bedside, right now, this is the most comprehensive assessment. But if we want to do something lighter, let us understand that psychosocial assessment is something very briefly, where we just don't have to ask for what is the last intake or what was the substance use, but we need to assess the patient holistically. So we talk about patient readiness level. First of all, the information has to be provided to him, and then he will tell he or her will tell in his own terms that what does he understand with it, what is the treatment like, what is the procedure like, what are the expectations from the procedure. A lot of times patients are in for a shock, where we see a lot of adjustment reactions post transplant because the expectations and the reality does not match. Second thing is the social support system. How strong is the family to support him? Do you have people to take care of you? You might need 2 rooms. You might need this much of financial budget. Are you mentally prepared for the same? How much is the caregiver burden? Is the caregiver already overburdened? Do you want time to call extended family members? Third thing is the psychological stability and psychopathology. Is there at any point, is the patient screening positive for any kind of depression or anxiety symptoms? Is there any worries? Is there any extra stressor in your environment which is ongoing? Fourth thing, lifestyle and effect of substance use. The last intake of your substance. What are your plans about the substance? 99% of the patients say, I will not touch substance again. But again, we have to understand what are the risks of relapse, which we will discuss in later. So based on this, the risk stratification is made, and we keep in touch with the higher risk patients. And it's not just SciPAT, but there were multiple tools which have been identified. PACT was the initial one, psychosocial assessment for candidates for transplant, but it had limited validation. Then it was soon replaced by TERS, that is the Transplant Evaluation Rating Scale. It improved the inter-rater reliability, but still it is largely qualitative. Then came the SciPAT, which we have just discussed about. Next was the joint recommendation by the International Society of Heart-Lung Transplant, as well as the Academy for Psychosomatic Joint Recommendation. This is not a scored scale, but they have given a guidance that how should the clearance and evaluation be taken place, what questions to ask. Finally, a special mention for the pediatric transplant rating instrument, which is the first standardized instrument for pediatric transplant candidates, because it incorporates developmental and family perspectives. So additional items here are what is the family environment like, what is the understanding of the family members. So that is also something which we plan to include in our subsequent pediatric transplant candidates. Now, what is the risk for relapse in alcohol users? So we can discuss three scales briefly. First was the HRAR scale, high risk alcoholism relapse. It was a more of a historical severity marker with just three components. What was the duration of drinking? What was the daily consumption? And what were the prior rehab attempts? Thereafter came the sustained alcohol use post-renal transplant. This has four components. It is more likely to identify that who is less likely to relapse. So like a rule out tool. And latest one is the harmful alcohol relapse after renal transplant, the HALT scale in 2020. This also has four components with age, pre-transplant abstinence period, more than 10 drinks per day, and legal or criminal history. So this is again a specific risk model. If you ask me, none of these scales are perfect. They all have their own pros and cons. They can help us to identify the high risk candidates, but they cannot replace clinical judgment. This was also subsidized by a study that we had done in ILBS in 2023. The observational study was carried out between July 2011 till March 2021 for patients undergoing liver transplant. Now, in the study, there were 203 candidates who had undergone liver transplant between this period, and the relapse rate was 9.85%. Interestingly, they found out newer protective factors which was never mentioned in previous scales. For example, protective factors, one of the protective factors was donation from spouse or first degree relative, which can decrease the risk of relapse. And a few new risk factors for relapse which was lack of family support apart from the history of daily intake, prior relapses, and shorter abstinence period. In another latest study, which was done by Young et al., published in 2025, they had gone through 69 adults in Duke University Hospital. They compared their risk factors with the already standard psychometric scales such as SALT and HALT, and they saw that these scales performed only modestly in their cohort. They also identified newer factors like those significantly increasing the relapse, such as significant psychiatric comorbidities, also the history of alcohol use even after cirrhosis diagnosis. Another interesting thing that they found was heavy alcohol use or legal issues did not predict relapse in their cohort. So these two evidences tell us that findings are there for additional predictors, and these suggest opportunities for further optimization of prediction scales, and that relapse risk doesn't end at transplant. It follows the patient into survivorship. So that is the time where follow-up gap can be dangerous. Now let's come forward in the continuum into peri or immediate post-transplant psychiatry. The most common calls that we receive during this point is either of delirium or adjustment disorder. So what does this anecdote teach us? There was a 49-year-old man who was on post-op day 7 in HDU. He had sleep disturbance, pulling of tube, and was disoriented to time. But when we were talking to him, there was no mood or psychotic symptoms, no catatonic features. So, but he did give us history of chronic sleep disturbance since 1 year prior to the transplant. The impression was delirium, and we added tablet melatonin, tried to improve his sleep-wake cycle, incorporated whatever sleep hygiene tips which were possible. The good thing was that we had optimally been able to manage the sleep disturbance without needing to increase the antipsychotic load. And not all delirious cases may require antipsychotics for symptomatic management. Managing the underlying abnormalities remains the mainstay of the treatment. Another patient with adjustment reaction, this was a 50-year-old woman who had post-op day 15. She was having a lot of crying spells, low mood, sleep disturbance. She actually belonged to Kashmir. So the language, the food unfamiliarity was there. She was feeling very lonely, intense longing of family. But in whatever interview that we could conduct with her, there was no depressive cognition. So she was not depressed. It was an adjustment reaction. We gave her repeated reassurances, supportive psychotherapy with gradual increase in her family contact and sleep-wake cycle ensured. There was no requirement of antidepressant, and her symptoms resolved within 2 weeks after the contact with family members was increased. So not all post-transplant distress is depression. Context-driven symptoms can also mix up the presentation. Now, what do studies tell us? The most common psychiatric problems, like what we have also collected in our data, is sleep disturbance or insomnia in 10.8%, followed by delirium. Next most common group is the neurotic symptoms such as depression, adjustment disorder, anxiety, and the lesser common ones include medication-induced syndromes and organic psychosis. Now, quickly just going through it, delirium, the incidence is 10 to 47%, with hypoactive type being the most common and also the most easily to be missed. It can have multifactorial reasons, but the primary prevention strategy is to target the multiple risk factors, ensure there is no sleep deprivation, try to for early mobilization as soon as possible, ensuring there is no sensory impairment, no dehydration, to ensure that the patient is oriented. All of these prevention strategies often prove to be more effective than the pharmacological treatment given once the delirium has already started. Next is sleep disturbance, most frequent complaint. The task is to understand the underlying cause of the sleep disturbance. It might be anything: organic, environmental, stress, neurotic disorder, delirium. The best management is to ensure whatever sleep hygiene tips can be ensured, and if that is not possible, then safer pharmacotherapies are always preferable. Third comes the medication-related psychiatry syndrome, steroids, tacrolimus, cyclosporin. Steroids have been associated with mild to severe symptoms, and it usually starts within the first 2 weeks of treatment. If the steroid dose reduction cannot be done, then symptomatic treatment with psychotropics is necessitated. Out of tacrolimus and cyclosporin, they have some amount of neuropsychiatric side effects, but cyclosporin has been seen to have lesser neurotoxic effects than the two. So why do these matter? Because a lot of times behavioral changes are easily mistaken for primary psychiatric illness, but a simple dose review can often resolve symptoms faster than adding an additional psychotropic. Now, every time there is a call for crying spell, homesickness, poor sleep, decreased interaction, it is not necessarily depression. What I learned that non-pharmacological interventions work best in the long term. Family engagement, ensuring adequate sleep. This can avoid use of excessive medications or antidepressants. If the symptoms remain unresolved, then we can plan to initiate pharmacotherapy. And the distinction is important because long-term management for both conditions differ significantly. Now coming on to the long-term post-transplant psychiatric continuum. So we were referred a patient who had his transplant done 1 year back, 42-year-old man. Now he's trying to adjust in his environment, but he came with a lot of sadness, impulsivity, sleep disturbance over the last 2 to 3 months. His planned business expansion has failed. Wife, he felt, has moved forward. She's working as a staff nurse. They are having to live separately. They only visit twice per week. He's viewing himself as failure and is also fearing that wife might leave him. This was diagnosed as adjustment disorder with current depressed mood. We talked to him. We tried to have a psychotherapy session where we were addressing the topics of role change, self-worth. He was mostly equating his professional failure as a documented self-worth evaluation. And we have told that we will be planning couple inclusive reviews. Only if the supportive session failed to bring improvement in the next 2 to 3 months, then we will have to add antidepressants. Another thing to keep in mind is that this trigger or this stressful event might also act as a trigger for relapse. So relapse prevention therapy has to be ongoing along with this. So we learned that successful transplant cannot end psychiatric risk. In fact, survivorship can bring a lot of new stressors like role loss and identity strain. Even 10 years post-transplant relapses can happen. This was a case with one such 50-year-old man who came to us. The liver transplant was done from Chennai. After that, he had not been in touch with any de-addiction services, and he has relapsed since the past 5 months after marital strain. Because of this, he is having no social support. We had admitted this patient, he had underwent detoxification, motivation enhancement, but unfortunately, motivation is not strong enough. So eventually, rehabilitation center was chosen for a long-term management. Currently, he's doing well for the last 6 weeks. But what we learned is that long-term alcohol relapse can happen, but it is preventable with follow-up through early identification. Now, studies tell us that survivorship can bring us new stressors, henceforth psychiatric comorbidities. 20% of recipients can return to alcohol by 1 year and 40% by 5 years. Regular follow-up, treatment adherence have shown better prognosis because modern outcomes it's not just about survivorship, it is about quality of life, functioning, mental health, and substance relapse. Now, what has our experience been like? The current services that we are offering is psychiatric and addiction consultations for chronic liver disease patients, pre-transplant evaluations and donor assessment, twice weekly post-transplant inpatient rounds, post-transplant OPD follow-ups, and we are taking up newer research initiatives to develop towards a transplant psychiatry clinic. Till now, from April to August, we have done 451 pre-transplant assessments where there were 303 recipients. Out of the recipients, majority were male, 83%, with the mean age of 44 years. Out of the 148 donors, majority were females with the mean age of 40 years. Alcohol-related liver disease was the most common leading primary diagnosis of 43.9%. Amongst the post-transplant interventions done, 66, 50 were for recipient and 16 was for donor. Now we had applied 451 SIPAT-based psychosocial assessments. It is good to see that above 90% of pre-transplant recipient had scored excellent or good in the SIPAT list, whereas also above 90% of transplant donors also had scored excellent and good on the SIPAT scale. So clearance was ultimately given in 96.8% of completed assessments, which shows that our evaluation enables transplant far more than it blocks it. Now, amongst the pre-transplant recipients, the history of moderate to severe alcohol use was seen in 33% of pre-transplant recipients. This is consistent with the fact that alcohol-related disease was the leading transplant indication. For the for 5% had shown moderate to high risk of recidivism and 32 were showing low risk of recidivism. So these patients were kept in close follow-up, advice for adherence, and family members were counseled. 3.6 had shown mild depressive symptoms and 3.9% had shown mild anxiety symptoms. Amongst the donors, 0.7 had screened positive for mild depressive and 1.3 had screened positive for mild anxiety symptoms, whereas 1.3 had also psychotic symptoms. Now, post-transplant, most common diagnoses which we had seen for the donors were, for the recipients were adjustment disorder, delirium, and sleep disturbance, whereas for recipient, it was more common between adjustment disorder and sleep disturbance. 18% of post-transplant recipient had showed moderate to severe psychopathology as compared to 4.2 of the post-transplant donors, which shows that post-transplant recipients may have higher chances of developing newer psychopathology after the procedure. Another neglected domain is the caregiver burden. Pre-transplant, 25% of caregivers were hitting moderate to higher score, whereas as compared to post-transplant patient of 65% hitting moderate to higher score. This can have several reasons, like because the condition is so long that often caregivers tend to get adjusted with time, that this is the situation. But most of our cohort post-transplant was nearer to the post-operative period. So that new adjustment, the new event might cause some amount of over-reporting. This score can change if we follow them up long for a couple of months ahead, and we'd like to also notice the change as well. These are some of the information educative materials which have started to give to the patients, family members, caregivers for their information and understanding of warning signs, and that help is available. Now, what are our challenges currently? The loss to long-term follow-up, geographical barrier, and limited longitudinal data. So for this, we ensure regular follow-up for high-risk patients, involve their family members, provide options for virtual consultation, and also we are planning to develop a prediction model for psychiatric comorbidity and alcohol relapse. Through this, high-risk candidates can be identified, who eventually we will plan to send digital reminders for regular follow-up. Second thing is to enhance routine screening in the CLD stage itself. So earlier involvement, strengthening of consultation liaison psychiatry, and also development of a brief screening tool, like what sir was saying, that just briefly we can tick that yes, there is risk of depression, anxiety, or substance use relapse. Thirdly is the caregiver burden, routine caregiver mental health screening at which is an often forgotten population. Our vision is to formalize our current practice into a transplant psychiatry clinic, standardize SIPAT-based screening for all the candidates and donors, introduce caregiver screening burden, which we are already doing, and also build towards our own ILBS-specific scale for psychosocial assessment. My final take-home messages for today is that transplant psychiatry spans the full continuum. It is not just clearance, but pre, peri, and post, and even long-term. Second, standardized tools can improve consistency, but they cannot replace clinical judgment. So clinical judgment remains the central tenet. Third, psychiatric comorbidity can affect long-term outcomes. So earlier treatment, earlier identification is linked to better survival outcomes. Fourth, not all psychiatric morbidity will need medication. Some can improve even with non-pharmacological option. Our own data has shown that transplant psychiatry enables transplant and not gatekeeps it. Caregiver burden and long term follow up are under recognized gaps. We are trying to identify them during the screening process itself. And finally, we have an opportunity for an ILBS specific psychosocial assessment. This will help to identify high risk candidates and follow ups with high risk patients. Thank you very much.
Excellent, Akansha. We all enjoyed it, and I'm sure there will be many comments, but time doesn't permit. But I have three suggestions for you. One is that the HALT score and the SALT score are all for DDLT. We haven't got some very good score, and ILBS can develop a score. We also need to indulge with the nursing so that we have transplant nursing, which we can start. And of course, the faculty has to be educated. Like I learned a lot of how we should talk to patients and what we need to do. Any other brief comments, Ashok or anyone?
Because if someone has a transplant to be done, around 60% Canada. So advanced disease, they're getting frequently admitted, they're getting sick. So I think there is very minimum data on this coping mechanism during the advanced disease decompensation. So that is one area. Then second, post-transplant, we need a both you and Mohit have a clinic properly so that now we're getting residency is one part. Second part is coming to the track. I think Mohit has a review article that coming to the track. So in that case, employment, psychological, social stabilities, that is also bigger area to that.
Yes, definitely.
Lastly, there are many OBs like MAPFR or muscles which adds to the MET ALD may have a different, the obese people may have a different psychiatric build-up. So that also can be new tool. Thank you, Akansha. Mohin, thank you. May like to add here that the attendance for the students is mandatory in this class. Those who do not fulfill 75% attendance may not get entry cards for the exam. The same true holds for the faculty. They need to be here, which I find very thin numbers. So I'll request Dr. Daga to kindly issue the attendance for all so that they know that whether they can appear in December or January exam or not. Rajan.
Thank you, sir. So the topic is brain to gut control of fat absorption and implications for metabolic liver disease. My overview would be to discuss about the vagus circuitry, how the vagus nerve contribute for fat absorption, the gut-derived factors which are responsible, the appetite and the satiety center, organokines, hepatokines, and the therapeutic interventions. So how does vagus nerve and fat absorption link? This is the usual vagal neurocircuitry that is seen, that patients that the afferent fibers they usually pass through the nucleus or the pass through the tractus solitarius, finally reach the nucleus of tractus solitarius, and from there they coordinate the second order neuron. They coordinate with the glutamate, GABA, or noradrenaline post receptor synapses to the DMV. DMV is the dorsal motor nucleus of the vagus nerve. There is also close communication with the area postrema and the area postrema and other hippocampal connections. The efferent fibers, they travel through the vagus nerve, and when we see that the efferent fibers, they usually the right side they supply the posterior gastric and the celiac. The left side they supply the anterior gastric, hepatic, and the accessory vein. And some of the part they also supplies the esophagus. So NTS, they are the median fibers. They are fast fibers. They usually communicate with GABA, glutamate, catecholamines, or glycine. And their distinguished feature from the DMV neurons is they are slow and spontaneous intrinsic pacemaker activity. So this is the usual lipid uptake that occurs. It is usually diffusion gradient is there, with which the triglycerides or the monoglycerides they get absorbed. Same goes with the cholesterol esters by the SRB1 or the Niemann-Pick like channels. Once they are inside, they are taken up by endoplasmic reticulum, and with the ApoB48, they are transformed into the chylomicrons. Also, the MTP, which is the microsomal triglyceride, they also get attached. So this study was the basis of the overall concept that the brain to gut signal controls the intestinal fat absorption. The objective was to detect the activity of the DMV neurons to reveal their role in controlling jejunal fat absorption. So these mice, they were intraperitoneally treated with the clozapine nitric oxide injected. Once they are injected, it was seen that these mice, they failed to gain weight, even on high fat diet. There was the oral fat tolerance test didn't had a triglyceride surge, and the 24-hour fecal non-ester fatty acid release was significantly higher. Same was the 24-hour fecal triglyceride levels. So it was seen that the DMV, once inhibited, they reduce the microvilli size in the jejunal lining, leading to decrease in the fat absorption. Also, these microvilli, they also had decrease in the protein EPS, villine, aserine, and CDC42, which are histologically associated with the villus length and maintenance of the villus architecture. Further, what they did that they intraperitoneally, with the adeno-associated virus, they injected, they targeted the DMV, which resulted in, with this, it was seen that the chemigenetic luminescence was there in the DMV area, not in the nucleus tractus solitarius. And this also resulted in the same findings. That is, the on high fat diet, the mice, they failed to achieve, they failed to gain weight. There was the plasma triglyceride levels were low. The excretion of fecal NIFA as well as the fecal triglyceride were high, and the jejunal triglyceride level at the enterocyte was also less. So it was supposed that the suppression of the DMV vagus jejunum axis controls intestinal fat absorption by shortening of the length of microvilli. This association of vagus nerve with development of steatohepatitis has already previously has been studied, where the hepatic vagotomy mice compared with the sham operation. In NASH, it was usually seen that the low phosphatidylcholine, they induce steatosis, lower level of PC and PE ratio, that also induced steatosis, and double hit PEMT, these mice were resistant to diet-induced obesity. But after hepatic vagotomy, it was seen that the resistance to DIO was abolished. And also in these mice, it was seen that the after the vagotomy, the steatohepatitis, they were not, and the double hit mice, they were not having steatohepatitis as compared to those who were sham operated. Other features of hepatic vein, how it regulates the immune system, was that vagus nerve stimulates suppression of macrophage activation. Nicotine, it triggers the JAK2 and STAT3 signaling. Also, in another study, it was seen that the alpha-7 nicotine acetylcholine receptor knockout mice, they also result in promotion of NASH. So they use this purine. This purine is a naturally occurring isoflavone extract, which has a bidirectional regulator of phosphatidyl PI3K AKT signaling, and it inhibits the cell apoptosis. So when these purine was intraperitoneally injected, the mice similarly had failed to gain weight on high fat diet, and it started excreting high fecal NIFA as well as triglyceride. So this modulation of vagal nerve have also been clinically studied in the reversible intermittent intra-abdominal vagal nerve block on morbid obesity. This was the recharge RCT on obese patient of BMI 40 to 45 or 35 to 40 of more than one cardiometabolic risk factor. It was a V-block device, was laparoscopically attached. The two leads were attached both at the anterior and the posterior rami of the vagus nerve. And intermittently, this machine was blocking the vagus nerve activity. The predetermined primary objective was the mean reduction of excess body weight loss should be at least 10% compared to the patients who underwent sham operation. And the excess body weight loss in the patients who were having this vagal nerve block for, in this study, the vagal nerve block was considered for at least more than 12 hours. So the excess body weight loss was 24.4% versus 15%. It was overall a negative study as the predetermined primary objective was a 10% difference, but it was seen that nearly 25% excess body weight was lost because of this. The same group had also published in the Empower study where the B block versus sham. But in this study, the overall duration of the use of device was not determined, and they found that the outcomes were better when the more than 12 hours the device was working. Otherwise, in the whole cohort intention to treat, it was not different from the shams operation. Now, what are the gut mediators which are responsible for fat absorption or overall management? The first is the GLP receptor agonist released from the enteroendocrine L cells. They are appetite suppressing. They are usually gut derived, but the preproganglionic nucleus of the NTS in the second order neuron also produce GLP-1A. They act on the area prostrema, which is not in the blood-brain barrier. That is why they have an eversion effect. And most of the effect is due to the brain-derived GLP. These, they don't act on the hippocampus, the prefrontal cortex, or the VTA. GIP is has the receptors are seen in the hippocampal area. That's why the GIP agonism along with GLP agonism have a better activity. They decrease the activity of the orexigenic AGRP. We'll discuss this AGRP when we will be discussing about the leptins. They decrease the orexigenic AGRP or neuropeptide by modulation of the POMC and MCR4 signaling. They reduce the orexigenic drive, thereby decreasing the food intake. The mechanistic study of the GLP-1 was studied in this study where the biopsy confirmed NASH patient 14 patients. They were injected with liraglutide 1.8 milligram versus placebo for 12 weeks, 1:1. And the patient underwent hyperinsulinemic euglycemic clamp, stable isotope tracer, adipose microdialysis, and serum adipokine and metabolic profiling. It was seen that the patient who were receiving placebo compared to that liraglutide patients, they had better adiponectin level at the end of 12 weeks. The leptin levels decreased, and also the leptin to adiponectin ratio was also improved compared to the placebo. And they found that patients who were receiving liraglutide, the change in the NIFA was much less compared to the patients who were receiving placebo. And this was also seen in patients when they were receiving low insulin levels. Also, the endogenous glucose production from the hepatocytes were also better in the liraglutide arm, and the de novo lipogenesis change of percentage was also better. Further going on is the role of organokines. The most important one is the FGF21, which is a hepatokine. Produced by liver. In the liver, it increases the beta oxidation, gluconeogenesis, ketogenesis. It decreases hepatic triglyceride and cholesterol content, and it decreases the inflammation. And in the adipose tissue, it increases the adiponectin, insulin sensitivity, as well as the fatty acid uptake. In this study, where they assess the overall FGF21 reverses MASH through coordinated action of the CNS and in liver, where the treated mice, the FGF21, it acts by the co-receptor clotho-beta. So the KLB double hit or the GLUT2 mice, in that the percentage body change with FGF21 was not seen, but it was seen in the control mice. Also, the liver triglyceride levels, they didn't decreased in the double hit in the mice which were which were recombinase treated. So the data indicate that the FGF21 decreases the liver triglyceride content by signaling directly through the glutaminergic neurons, but the cholesterol metabolism is not guided by this neuronal activation. They also found that there was significant downregulation of the beta oxidation pathways, and the de novo lipogenesis was also blunted once after giving FGF in these resistant mice. In one of the human studies where the FGF21 was studied in the mast progression, biopsy-proven patients of 387, serum circulating FGF21 levels were assessed, and genotype assessed was RS838133 variant. It was seen that the significant high expression were seen in patients who were having MASH compared to those who were not. And on multivariate analysis, presence of single or biallelic A was significantly associated with development and progression of MASH. Other hepatokines, including the ANG, PTL, LEG2, or SHBG, they have all been linked and studied with the fat absorption and metabolism. Coming to the last of the organokines is the leptin. So leptin is usually get absorbed by the OB receptor. It is usually act by the POMC pathway. POMC is the pro-opiomelanocortin, which gets converted into MSH or the melanocyte stimulating hormone, and it finally acts via the MCR or the melanocorticoid receptor, MC4R. So the leptin, it decreases the food intake, while the AGRP or the agouti related peptide receptors, they are responsible for increasing the food intake. So the leptin melanocortin pathway is that leptin on the arcuate nucleus via the POMC, it has aneroxygenic effect, while the agouti AGRP, it has by activation of the MCR, it leads to obesity. In this study, where it was studied that not only the central leptin but also the gut leptin melanocortin pathway also modulates the intestinal lipid absorption. The aim was to identify the role of leptin signaling in the MTP regulation. MTP is microsomal triglyceride transfer protein, which is an intracellular chaperone for fat delivery. And it was seen that the semi-quantitative assay of the mRNA in the enterocyte for the leptin receptor, POMC, AGRP, and MC4R, they all decreased in the pre-treated mice. Finally, the adiponectin, which acts by two receptors. One is the ADPO-R1, downstream AMPK. It increases the mitochondrial fatty acid entry and decreases the de novo lipogenesis. And secondly, it also acts by the ADPO-R2 receptor, downstream by PPAR alpha, and it decreases the lipotoxicity, increases fatty acid oxidation, and increases mitochondrial biogenesis. Thereby, it says that the increase in the PPAR activation decreases hepatic triglyceride accumulation. Other adipokines studied are the omentin, resistin, and vaspin, and they have all been studied with the obesity and fat metabolism. One of the study where the recombinant human leptin, that is the metrileptin, was studied in 18 patients. It was a crossover study where 9 patients, they received either first placebo followed by leptin analog or leptin followed by placebo analog. And the hypothesis was that the metrileptin, it stimulates the hepatic lipid export via an autonomous nervous system in human. The decrease in the liver triglyceride was assessed by a magnetic resonance spectroscopy, and the peak plasma level was achieved in 4.5. After giving this metrileptin, the plasma level of leptin increased by nearly 30 times in those patients who were injected this recombinant. And it was seen that the VLDL triglyceride secretion rate significantly increased when patients were initially subjected to placebo followed by metrileptin. So to summarize, the intestine and the nutrient sensing organism, the dietary fat absorbed by enterocytes or fatty acid sensing mechanism through the enteroendocrine L cells or I cells and mediated by GLP-1 or GIP. They activate the intestinal sensing mechanism, and some of the signal by vagal afferent, they create a rapid gut-to-brain communication. But the vagal afferents via the nodose ganglion or the nucleus tractus solitarius or DMV, by action through hypothalamus and brainstem circuits, they also result in fat absorption and this bidirectional loop. Now, finally, to end, two more things that was seen was the one is the liver sympathetic innervation in mast cell using a 3D imaging, where the liver it was immunostained with these markers, and in mast cell patients, it was seen that the periportal vagal nerve in mast cell patient were significantly less compared to those who were normal or without mast cell. And second is this genetic study on BMI, where nearly more than 300,000 patients across multiple registries, they were assessed. And it was seen that for the BMI assessment, most of in this, they identified 96 alleles which were determining the high BMI, out of which 56 were novel. But most of these high BMI was associated with genes which were regulating the nervous system. Also, on this multi-cap connection, it was seen that the post-NMDA receptor activation and activation of NMDA receptor and glutamate was most linked to all other protein gene complexes. So it was said that pathways that respond to changes in feeding, especially the obesity-related molecule like the MCAR, they are also key for the genetic, as far as the genetic basis is concerned. Thank you.
Well, a tough topic
Yes, sir.
you picked up, Rajan, but yes, there are two things I can add. One is the work by Saddam
Yes, sir.
under Savneet. He also showed the sympathetic, actually traced the fibers to the hepatocytes.
Yes, sir.
But what is very interesting that you showed is that leptin
Yes, sir.
can reduce, and the trial that came in Nature, JAMA,
Yes, sir.
I think it's a very interesting concept. There is a concept of fat as the ileal brake, and fat decreases the gut motility,
Yes, sir.
and that is through vagus.
Vegas. Yes, sir.
So if you have people, we think fat will cause diarrhea, but it is actually an ileal brake. A lot more can be added. Any other suggestions or comments? All these are new information, so take it with an open mind and a huge amount of work. Thank you, Rajan. Yeah,
Obviously, the fat absorption is reduced by proliferating the gut brain axis, but the body will compensate. So the patient might start taking more carbohydrates, and the de novo lipogenesis might also increase. So the liver fat might reduce, that is a fair point. But has the work also discussed about the overall nutritional consequences on other organs, cardiovascular health, for this type of modulation? Have we reached that stage, or this is too early?
Most of the across searching for literature for many days, I could not come across many of these human studies. There were few which were just dealing with the mechanistic part. Even with the negative trial, they were all they were doing, but otherwise, most of these studies were based on the whole concept is on mice studies, and
I
so
can give you some data. The adiponectin receptor 2 is in liver, and receptor 1 is in the adipose tissue. So the balance between what you are saying, the adiponectin 1 and 2. So adipo R2 is in the liver, and the fat that you give also messages, but primarily to the liver. So the fat is taken up, and the adipo R1 is in the adipose tissue. Now the transport is by the macrophages, which are fat-laden macrophages, and that causes toxicity. In 3 days' time, if you have fat, the message from adipo R1 will go to R2 in the liver and you get toxicity. So this is lipotoxicity hypothesis. First adipose tissue, but simultaneously the liver. But that's a huge area, and I guess Rajan covered part of this. Thank you.
Yes, sir.
Vegas is,
Yes, sir.
vagopathy is
Yes, sir.
a major area. Is anybody from neurology, Dr. Kaul or Bhargavi? Yeah, what do you say?
I was actually thinking if we could on it in the sense whether there are any studies about vagal nerve, I mean, surface stimulation or anything with regard to the metabolism of fat, or reduction of metabolic level is associated with.
So the three studies that was that I had quoted was based on the laparoscopically placed devices, but otherwise many of these studies were also most of the concept comes from the bariatric surgery group only after doing the Roux-en-Y and the sleeve gastrectomy. But
You have the Genève tradition, that is the stimulation of vagus. People have this Genève, yeah, surface stimulation.
Yes, so we can.
Regarding vagotomy, it told that it causes increased lipid, decreases lipid absorption, right? Because of the villi size is decreasing.
yeah,
But why should it? So there are multiple problems here. Once you do vagotomy, the entire gut peristyle slows down, correct? So that causes lipid accumulation in it, and the bacteria will grow there. So, and also that also causes less lipid absorption. You don't have to say that there is what is the reason for. So the decrease in the length of villi may be an indirect consequence of that. And if that's the case, not only lipids, but all amino acids and other things also are going to the absorption is going to decrease.
Mm.
And another thing is that about leptin therapy. So in diabetes and other things, already there is leptin resistance.
Yes.
At very high. So giving more leptin, you should remember that it's all pro-inflammatory, highly pro-inflammatory.
No, so leptin is already high because of the leptin resistance. It doesn't cause satiety. In fact, through the other pathway, it increases the food intake
So-
because of the leptin resistance.
So giving leptin is harmful.
Yeah.
Should be harmful.
I agree with this. Thank you. All right, Rajan, thank you.
Thank you, sir.
Very good.